This is not just for practitioners like me who are in small private practices working with the people that can get to us. This is for every practitioner that works in traditional hospital-based skilled nursing, school systems, outpatient pediatrics, mental health, everybody. Welcome to the Fascia Informed Therapist podcast, designed for health and wellness practitioners interested in fascia science. I'm Amy Mayer, occupational therapist, practice owner, author, and educator with more than 30 years of experience using fascia techniques across many settings. Each episode brings practical insights and thought-provoking conversations to help you expand your skills and better serve your clients. Let's get started. Hi, this is Amy, and this is another edition of the Fascia Informed Therapist. And today we'll be looking at an article in the the International Journal of Molecular Sciences. The author's name is difficult to pronounce. This is out of Poland. The last name is Zielinski. The first name is Grz, Egorz. And I did look up at how to pronounce it, but I'm still not confident I'm going to say it correctly, so I'll spell it for you instead. The title of this article is called The Future of Fascia, a scoping review on emerging research, trends, and recommended sample sizes and effect sizes in fascia studies. So why does this matter to us? Well, I've been talking for a while now that, gosh, we know a heck of a lot about the anatomical aspects of fascia. I think it's not done, of course. I mean, even other body systems are still, our understanding is evolving of a lot of the body systems, and it's most definitely going to continue to evolve when it comes to the fascial system. But what I'm saying is we know enough about fascia now to be able to, the researchers to be able to include it more as a variable in studies looking at more the clinical things that we care about as practitioners. And so that is basically what this article is talking about is they looked at a lot of the past studies, and they looked at the size of those studies and the effects of the results of those studies, and then are making some hypotheses about what needs to happen in fascial research going forward, particularly when it's being looked at in a clinical context. So, and then they're also making some hypotheses, some best guesses on where the focus of the clinical research around fascia is going. The first direction that they talk about as far as clinical studies happening in the future, they're talking about the myofascial unit concept and not looking at sort of taking away the looking at things in isolation. So looking at fascia versus looking at muscles versus looking at bones. They're talking about the myofascial unit. I'm going to read you something from the article. Stecco, of course, we know Carla Stecco. She is a total badass in the area of fascia and has put out some really wonderful articles and books that if you haven't looked at, I would highly recommend. So Stecco et al. Introduced the concept of the myofascial unit as a fundamental element of motor control. This model emphasizes the interaction between muscles, fascia, and intermuscular connective tissue in generating movement. Dysfunction in one component can impair the others, reducing functional capacity. By moving beyond the traditional view of muscles as the sole organizers of motion, this framework provides a more comprehensive explanation of myofascial pain and proprioceptive dysfunction and offers new diagnostic and therapeutic opportunities. The second area that the author is suggesting that fascia research is going to move towards is fascia's role in chronic pain, but particularly in older adults. So looking at chronic pain through a fascial lens, altered connective tissue structure, reduced glide, persistent tension, and how that's contributing to ongoing pain and disability, and that it's likely that that is an area that is going to be studied quite a bit, because that's an area where a lot of services are being used. So how can we help these people, these older adults, have less pain and have more function? And that's better for them, and it's better for the economy, and it's better for everything. So that makes sense that would be an area to move towards. Excuse me. So another bit from the article. Du et al. Examine the role of fascia in chronic pain, particularly among older adults. Their bibliometric analysis of 744 publications identified, those are from 2013 to 2022, identified major research centers, leading authors, and thematic directions. Fascia is increasingly recognized as central to the development and persistence of pain, with modern imaging techniques facilitating detection of pathological changes. Key topics include myofascial pain syndrome, nerve blocks, and intervention therapies such as yoga, acupuncture, and Tai Chi. The third area, they're talking about more integrated interventions. And that essentially just means more types of interventions working together. So the research studies might look at combinations of interventions like manual therapies, plus movement-based, plus neurophysiological and imaging, neurophysiologic interventions and imaging tools, so that we can see what's happening in different areas and different body systems, different areas of the body and different body systems. My apologies. Okay, so this, I think, really speaks to a couple things in the past, and being taught manual therapies and myofascial work, and it's often highlighted that if you just do this technique on somebody, it's going to help them, it's going to fix them, it's going to change their body, and they're going to suddenly be able to do everything that they want to do, because they have less pain or a more open fascial system. I think that does happen sometimes. I absolutely think that happens sometimes, but I think it's a far better approach to, once somebody has less pain, their body feels better, that you help them move better. And when they move better and they have better posture, they're much less likely to end up in the same boat that got them to your table in the first place. So studies are going to be looking at that, because that is the hypothesis of this author, because they looked at past studies. And what were the studies that got results? Studies that had more of an integrative approach, meaning they just didn't do one intervention. People often need more than one thing. And then the fourth area that is brought up is looking at outcomes that actually matter to function. So moving away from like lab-based measures. So looking at something that we can measure in a lab versus something that's functional. So thinking more about measuring pain outcomes, because pain reduces function, right? And the gait quality or ability to do a transfer or fine motor function or participation in occupation, getting back to daily life, doing back to the activities and occupations that matter to us most. So looking at those kind of outcomes, of course we care about that that very much. We want our people to have better quality life, and that means being able to do what they want to do, not just simply do they have pain or not. And often getting them back to those things. And people who are well, taking care of their pain is probably going to get them back to their function in daily life. But people who are, those multi complex people, they're going to need more than that. Fascia offers a more complete view of the body and how we can support function and healing. In the Occupational Therapy Practitioner's Guide to Fascia Informed Practice, I help you explore the powerful role of fascia in everyday client care. Through my live and online courses, you'll gain practical hands-on skills you can use right away. Explore fascia, integrate skills, transform care. Visit fasciainformed.com to learn more and start your journey today. Okay, so now let's talk about what they're suggesting in terms of what the research is going to look like from more that research lingo perspective. And I'm going to try and keep it as simple as possible because I need it to be as simple as possible. That was always, for me, working in academia was, it's always best to work with a statistician and let them try to explain this sort of aspect of research in the most simplest terms possible. So my OT brain doesn't always wrap around that as quickly as I would like it to. Okay, so the authors are basically saying that the effect size used in past studies wasn't the best because they weren't picking up, or we might have been overestimating or giving more credit to the outcomes than perhaps the outcome deserves. And we need a smaller effect size. And that basically the expectation should be, when working with fascia, that there will be more subtle, meaningful changes, not these big, miraculous changes that we like to think we can do. And sometimes we can, because I see it all the time. When you go in and you do the work and you teach somebody what to do with their bodies, you can make big changes in one visit. You absolutely can. I will tell a quick story. I had a friend visiting me over the last week, and she came in from out of town, and about a month ago she broke her wrist. Didn't heal, so they ended up doing a surgical intervention, and she was 2 weeks out from that, and she was told she could take off her splint, she could do active range of motion, just stay in that pain-free range. But she was still having swelling, and she was very stiff and still very limited in her range of motion. And she also had limitations in sensory sensation around the wrist area. So I asked her if I could offer a little help, and I said I will tell me in detail whatever limitations that you have or things you're not supposed to do, and I will work around those. So all I did was I started at the elbow, I worked towards the wrist. When I got to the wrist, I asked a lot of questions about how it was feeling, and I lightened up quite a bit. But I went from the oh my gosh, I can't remember right now. It was not the palm side, the back of the hand side, from the elbow down. Oh my gosh, my word finding. And then I went on the inside, palm side of the forearm, and went from the elbow down, and just went extremely slow and really respected the tissue tension. And then I went to the scar And I used everything I learned from that wonderful book that I talked about in past episodes on scars. And I don't have it in front of me, and I'm not remembering the author. Started with a T. Jan Tarwarth, I think it is. So sorry. I'll put it in the description. But I used what I learned from that book and worked on her scar. And when I asked her to move around a little bit and see how she felt, and she was flabbergasted is not too much of a word, and how much different her arm felt. And she said, I immediately can feel like there's more fluid exchange. Everything feels softer. She said, I feel like I can see the veins in my arm better. It looked less and felt less puffy to her. I think we definitely moved some fluid. She said, I feel like I can feel when I move my wrist. She said, I don't feel like I can move it up much further than I could before, but I feel like it feels more normal when I do move it. And she said, I feel like I can feel what's happening inside my forearm, my wrist, and my hand better. So to me, that is massive change and serious. I probably worked on her for not even 30 minutes. So that's huge. So we can, what I'm saying, the reason I told that story, I didn't intend to tell that story today, but is we can see those big changes, but we can expect that, especially in some of them, I think, more complex systemic, like myofascial pain syndrome or fibromyalgia or chronic fatigue, some of those types of things. We're not going to see those big changes that quickly. It's going to happen slowly, and it's probably, they're going to be, 2 steps forward, 1 step back kind of thing going on. So also, one of the things that they're saying is the future studies absolutely need more participants, and they're saying around 60 participants is more likely to catch the effects that we're looking for. So those are, I think it's always difficult to do these kinds of studies. I really and when you're thinking about these kinds of studies too, they're not something that's going to, it's not like a pharmaceutical study where you do the study and that's something that you can sell and somebody's going to make a lot of money. These studies don't net big bottom lines for people, so it's likely more difficult to get funding to do these types of things. And I know there has been funding out of the National Institute of Health here in the United States, but I don't know what that still looks like. With a lot of funding has been pulled over the last year, and it's probably pretty tough. They're probably really having to focus in and really make decisions about what priorities are, and I don't know where fascia falls in terms of that. So if some of you out there are on the academic side and this is something that you're interested in doing, this would be an interesting article to look at if you're planning something. I can tell you I will not be organizing any studies unless some academic institution wants to pull me in. I'd be absolutely happy to be a part of it in some way, whether that's planning interventions or gathering participants. That could absolutely be involved in that as well. But that is where this author is suggesting that the research is likely to go, and how we need to be looking at it in terms of actually structuring the participant size. So I hope that this gives you some thinking fodder for, yes, you need to know the anatomy. And this is why I created the anatomy class that I created, because I believe everything I've pulled together is what practitioners need, particularly my field, occupational therapy. We need to understand this system because it is going to be a focus in future studies, and this might be what the author here is saying in terms of we're going to be looking at older adults and chronic pain. We're going to be looking at this myofascial unit in terms of movement, primarily movement, but also pain. But it's already a variable in cancer studies. It's already a variable in myofascial pain studies. It's already a variable in many, many, many areas of practice that we care about. This is not just for practitioners like me who are in small private practices working with the people that can get to us. This is for every practitioner that works in traditional hospital-based skilled nursing, school systems, outpatient pediatrics, mental health, everybody, not just the non-traditional small private practices out there. So I hope you found that interesting, and I will link the article in the show description and also the name of the SCAR book that I couldn't get off the tip of my tongue. But thank you so much for listening, and I hope everybody has a wonderful, wonderful day. You've been listening to the Fascia Informed Therapist podcast. Be sure to subscribe so you don't miss new episodes. And if you'd like to go deeper, check out my continuing education courses, both online and in person. You can find them at fasciainformed.com. Thanks for listening, and I look forward to next time.